just keep moving since I've lost about 10 minutes, and hopefully this is not too much of a distraction for those of you that are joining. I just want to say good afternoon and that I'm Andrea Stubbs, and I'm the Administrative Director for St. Jude Children's Research Hospital's HPV Cancer Prevention Program. And I just want to thank the organizers for inviting our program to be a part of this very informative and timely conference. And our program leader, Dr. Heather Brand, is taking a much needed vacation and asked if the organizers will allow me to share just a few evidence-based strategies we strongly support that help contribute toward building HPV vaccine confidence. Next slide, please. I do not have any financial obligations to disclose, so we can just move it on. Yes, thank you. And I'll use our time together to briefly share updates on how we are building the HPV cancer prevention program, just touch on the potential opportunities for impact of the program and highlight multi-level and multi-component interventions to increase HPV vaccines in clinical practice while sharing useful and established message framing techniques to parents that will help to aid in making, or hopefully help to aid in making the decision to vaccinate a little bit more palatable. Next slide, please. And I'll just share a little bit about our programs. If you could just go to the next slide, please. Thank you. Since the founding of St. Jude in 1962, the St. Jude clinicians and researchers have asked and answered what if questions that have changed the landscape of childhood catastrophic diseases. And today, the hospital is guided by a strategic plan that outlines a bold strategy for the future, but other opportunities arise constantly. And this begs the question about how to identify and pursue bold new projects that could further transform science and medicine. Dr. Jim Downing, who is the president and chief executive officer of St. Jude, has initiated a process to look beyond the provisions of a strategic plan and embrace the possibilities of accelerating the hospital's mission. And all faculty and staff members can submit blue sky ideas. Next slide, please. And one such idea came following Dr. Downing's participation in a national meeting focused on transforming cancer research. It was through these meetings that he learned of slow uptake of HPV vaccination to prevent some types of cancer. And Dr. Downing shared his observation with Dr. Charlie Roberts, who is the director of the Comprehensive Cancer Center here at St. Jude. And also he shared this idea with other clinicians and team members just about developing a blue sky idea, asking, what if we at St. Jude could accelerate efforts to prevent adult cancers by vaccinating children? And as Dr. Roberts and others have noted, while we do not yet know how to prevent pediatric cancers, there is an opportunity to support a safe and effective and durable vaccine given to children to prevent HPV-related cancers. Next slide, please. And the past 6 months have included a whirlwind of planning and developing infrastructure by the beautiful faces seen here. Each of us have spent countless hours masked up in person at times and virtually, and sometimes on the phone working through establishing the development and processes of our program. And Dr. Brandt bravely started at the peak of the pandemic in July of 2020, and Ursula LaFleur is our administrative specialist, and she started a few months after Dr. Brandt, and Carol Miner and Julia Neely, our program coordinators, all started within the same week as I did, and that would be in January of this year. Each of us brings a unique lens and skill set to the HPV program, and we've thoughtfully planned over the past 6 months how best we could actualize the goal of the St. Jude HPV Cancer Prevention Initiative, which is to prevent virus-associated cancers through increased HPV vaccination. Next slide. We have just a short window to really influence and impact HPV vaccination uptake, and thought it best to prioritize how resources will be used to achieve the most impact. These 4 areas shown here represent spaces in which we envision the new program operating. This includes community engagement to address disinformation and build confidence in HPV vaccination. We also recognize the important role of healthcare providers and systems in delivering HPV vaccination and the critical influence of a healthcare provider's recommendation. Partnerships will serve as a foundation of our efforts, and we know there is excellent work happening. And so we want to support these efforts as much as introduce new efforts where they are needed. Public policy and advocacy efforts will also play a big part of the new program. And we know a favorable policy environment can support HPV vaccination efforts locally. And within these areas, our program will be working in the greater Memphis and Shelby County area and extend to the state of Tennessee, the Mid South, and Southeastern US, hopefully to the nation and perhaps even globally in the future. And we have the power, we believe, to prevent the 6 types of cancers through HPV vaccination. We are attempting, next slide, please, sorry. We are attempting to organize our efforts by each of our staff becoming a standing member, representative or fixture in a prospective state, region, or catchment area. And this simply means engaging with local and national roundtables and serving as a content expert or community resource connector. Next slide, please. We'll just talk a bit about opportunities for impact, and so we can move to the next slide. Thank you. These are 2 maps we study often as we approach new ideas to reach our goal. And many of you may have seen this slide before and likely zero in on your state or your region. For us, the deep southern region has a long way to go. For us, just like you, has a long way to go in comparison to other regions of the country. And our program thinks about how we can be a part of changing this picture and telling the story of HPV vaccination as cancer prevention. And 16 years after the licensure and recommendation for a safe, effective, and long lasting vaccine to prevent HPV cancers, the map on the left shows us the slow uptake of HPV vaccination in many parts of the US. The states that fall within the outline of the green circle show us where there are the lowest rates of HPV vaccination uptake, in addition to the 4 states in the Intermountain West. And these are all proximal to St. Jude in Memphis. And so this map of HPV vaccination uptake is contrasted by the map on the right side of the screen showing incidence of HPV related cancers. In those same areas with low uptake of HPV vaccination, we see the highest rates of HPV cancers, including anal, cervical, oropharyngeal, penile, vaginal, and vulvar. There is substantial opportunity for impact by changing both of these maps to show high HPV vaccination uptake and low rates of HPV cancers. Next slide, please. There's a major discrepancy in HPV vaccination uptake in the southern US, where we see high disease burden. These maps tell a story of opportunity, and we see this as a tremendous opportunity for impact as we recognize that each number represents a person, a child who may be vaccinated today to prevent cancer in the future, a young woman who dreams of having a child someday diagnosed with cervical cancer who was unvaccinated, a man and a father of 4 diagnosed with oropharyngeal cancer. And this is also an opportunity for the state of Arkansas. You guys have already produced an HPV report and starting to focus efforts in this space. And I see this as a prime opportune time for collaborative efforts and just moving some of the initiatives that already working well forward. Next slide, please. The NIS teen data is the best data we have to track and monitor HPV data for boys and girls 13 to 17 years old. And what I have pictured here is a closer look at selected southern and mid-southern states to show the differences in HPV vaccination greater than or equal to 1 dose, and also those that are up to date. The first column shows the number of percentage of 1 or more doses, and the second column shows the completion of the 3-dose series or up to date. And you can see here that Arkansas is actually doing better than other southern neighbors, but still fall below the US average. Next slide. And now specifically for HPV vaccination, geographic disparities are also significant, in a place where we really should pay close attention. This map shows the 2019 NIS teen data for up-to-date HPV vaccination coverage among 13 to 17-year-old adolescents. And for context and ease, I'll just clarify that the lighter colors denote lower levels of uptake. And there are major differences, especially in the South and Intermountain West. Across the South, in particular, Mississippi has the lowest uptake of HPV vaccinations at 30.5%, and Louisiana has the highest at 59.5%. And the mean across the southern states is about 5% lower than the US average. And while there have been improvements, geographic disparities still continue to persist, and rates can also differ significantly within a state, a territory, or a jurisdiction. And if I were to show you a map of HPV cancers in the US, much like what we saw in the previous slide, you would see in these areas with the lowest HPV vaccination uptake that there are the highest rates of HPV related cancers. And we must identify regionally appropriate strategies to account for the uniqueness in geographic regions with low HPV vaccination uptake to prevent these cancers. And to take this one step further and integrate insurance coverage, there are 12 states that have not expanded Medicaid, with 8 of these in the southern US region. In a recent study published by Hoff and colleagues on the association between state Medicaid expansion and HPV vaccination showed significant increases in HPV vaccination after states expanded their Medicaid program. And the largest increases were among individuals below the federal poverty level and among those below $75,000 annually for a family income. And in another recent and related study, it was found that provisions of the Affordable Care Act were associated with increases in HPV vaccination series completion. And so the result of this study suggests expanding Medicaid across the remaining states could increase HPV vaccine completion among publicly insured youth and prevent HPV-related cancers. Next slide, please. Here is another look at HPV vaccination with other adolescent vaccines. Tdap and meningococcal conjugate vaccine. They are both recommended for 11 to 12-year-olds in addition to HPV vaccination and seasonal flu. And this is the traditional CDC coverage with the routine adolescent vaccines for the span or the NIS teen data. Coverage for all vaccines have increased, and there is a sizable coverage difference in HPV vaccine coverage compared to Tdap and meninge. And I'll also point out that the vertical line at 2018 is to identify when NIS identifies when the NIS teen transitioned from a dual frame to a single sample frame survey. And also, it is worth mentioning that these two measures for HPV that denote that the HPV series has been completed, and the Advisory Committee on Immunization Practices changed the definition in 2016 from a 3-dose to a 2-dose schedule as described earlier. Next slide, please. And I'll just skip this one just for the sake of time because I don't want to run out. And if you don't mind going to the next one, and we'll talk about healthcare provider and healthcare system related interventions. Overall, next slide, please. Overall, for HPV vaccination interventions, there is a blend of evidence-based and recommended approaches that focus on ensuring supply and generating demand. And these approaches work best in combination and are multi-level and multi-component, even showing multifactorial aspects within levels and components to accommodate for context. And this is just a snapshot of recommended approaches from the community guide. And you can go to the next slide for more in depth. And so we see here that healthcare systems and healthcare providers, where the blue screen is, are critical for HPV vaccination. And this is a supply side and need to be ready for the building the confidence in HPV vaccination among parents and as well as caregivers for their children and those who are age eligible. This combination includes at least one intervention to increase client demand, such as client appointment reminders or recall or client-based education paired with one or more interventions that address interventions to enhance access to vaccinations or those directed at providers or systems such as provider reminders and standing orders and provider assessments and feedback. And community pairings could be manual outreach and just tracking or interventions to enhance access to vaccination services. And that really could be expanded access in healthcare settings such as home visits and reduced client out of pocket expenses is also a value add for this process. Next slide, please. And so we've learned a lot over the last decade or so about how to communicate about HPV vaccines. And one of the best practices for increasing vaccination uptake is to normalize the conversation. And one of the strongest practices is to recommend HPV vaccines as part of routine adolescent immunization. And what you see here is a formula, and I must give credit to Doctors Noah Brewer and Melissa Gilkey, and we can make sure to share that link, or we'll share the slides, I would imagine, for reference here if you'd like to read more about it. The presumptive recommendation is first, you note the child's age, then announce that the child is due for vaccines that prevent several diseases, and then you say you will vaccinate. For example, now that Kara is 11, she's due for 3 vaccines to protect against meningitis, HPV cancers, and whooping cough. We'll give them at the end of the visit. This presumptive approach is not new for many of you, but I just wanted to emphasize that the idea is to place emphasis on that HPV vaccines are like any other adolescent childhood vaccination and part of the routine vaccination schedule, and hope that it becomes the normal way these vaccines are introduced to parents and adolescents. Next slide, please. Here shown are 2 additional steps if a parent pushes back, and these can be helpful provider tips that may be beneficial when parents or when providers experience some pushback or offers other forms of communication to address a parent's concerns or responses. And the approach is refined by additional steps of connect, and that simply means to ask the parent their main concern, and then counsel, which involves reflecting and affirming and addressing their concerns using a research tested method. Next slide, please. And we know that adopting a new practice change is not simple, and it involves change from check in to the checkout process from a clinical visit. And it won't always be a seamless process, but these steps listed here have been shown to help providers achieve success when implementing new approaches. Follow the evidence based practice standards, guidelines, and recommendations to assure that that all clinic and staff have the knowledge and skills. It's also important to consider professional norms and peer influence and recognize that external pressure and incentives and expectations for improvement are also impactful. Um, Evidence of deviations from recommended practices that are accepted by providers are valid and accurate, and understand also that the etiology of deviations and what they could be, like what are the root cause drivers or the influencers or the barriers or facilitators that contribute to low uptake of vaccines, and ask, are there methods that are feasible to be operationalized within the clinic setting? And if they aren't, be willing to make some adjustments and changes. Next slide, please. And I wanted to just point out that there are several supportive resources that help put this all together. And these resources can easily be accessed through partner agency websites or local regional support staff. And the steps are there. And I want to just, for the sake of time, just move past this if this is okay, just so that we'll have a little bit of time to talk about vaccine confidence. And so we know that it's important building vaccine confidence with the trust that parents and patients or healthcare providers have in recommended vaccinations, providers who administer vaccines, and processes that are led to vaccine licensure and the recommended vaccine schedule all have strong influences on one's ability to move forward in the vaccination process. And part of our role is to make sure that these groups are confident in vaccines and using evidence-based recommendations to proves to be a value add for the clinical setting. So next slide, please. Vaccine hesitancy is very common, but it's also a continuum. Vaccine acceptance occurs on a continuum of levels of vaccine confidence and acceptance. And refusing all vaccines is on one end, and accepting all vaccines on time or as recommended is on the other. And somewhere in the middle emerges hesitancy and reluctance or refusal to vaccinate despite availability and access to vaccines. And in simple terms, vaccine hesitancy leads to refusing some vaccines, delaying some vaccines, and accepting some vaccines. For those who experience vaccine hesitancy, working to build confidence in vaccines is paramount, and vaccine hesitancy threatens to reverse any progress that has been made over the years in tackling vaccine preventable diseases. And in fact, the Health Organization named vaccine hesitancy as one of the world's top 10 global health threats in 2019. Next slide, please. And some prominent challenges that have emerged as factors that diminish vaccine confidence centers around access to the vaccines and individuals' awareness of the vaccine and the virus itself, where they fall along the continuum of willingness and acceptance. And individuals have valid questions and concerns about benefits, the safeties and side effects of vaccines, and their concerns about speed of development of the vaccine and diverse representation to create the vaccine, to affirm it, and to recommend. And one must also be aware of distrust in political and economic motivations that are prevalent. And some of the apprehension is fueled by um, very convincing conspiracy theories about vaccines. And I think I would be remiss if I did not mention that much of this is being lived out and played out in real time as we see the COVID-19 pandemic second wave rear its head again. And these factors contribute to decision making that keeps individuals from vaccine uptake and unfortunately poor and even deadly outcomes in some instances. And we had sort of jumped ahead a little bit. So that slide that's just been showing is just, we'll skip past that for the sake of time, but it should make lots of sense. And the next slide, please. Yeah, thank you. The majority of parents are not definitively dead set against HPV vaccination. Many of them often feel that they need more information. And initially, many of the parents will experience some hesitation with allowing the vaccine. However, many of them go on later to allow the vaccine once they have their questions and concerns addressed, which affirms just how important a recommendation from a healthcare provider and their clinical team is. Next slide, please. In addressing Black, Indigenous, people of color, and considering how these groups are already severely impacted by systemic injustices, there are specific strategies that have been shown to increase vaccine uptake. And they specifically offer support on how to address barriers around access. And for instance, offering mobile clinics or pop-up clinics and options of home visits or reassurance of confidentiality of immigrant status would be just things to consider when working with BIPOC communities. And also considering that engaged community leaders, such as faith leaders or traditional healers, are trusted messengers that can help to support vaccine uptake. And consider also customized vaccine education using existing local media, radio, and allow people to ask questions and receive honest, transparent responses to those questions. And one final recommendation is to leverage support from key stakeholders of professional organizations. Next slide, please. And we'll talk just a little bit about how to overcome some of the challenges with practical tips. And if you could just focus your attention on the blue box, you'll find helpful recommendations for healthcare professionals. And basically, just start early, build a trust with parents, choose the messenger of vaccine information, and choose the messenger carefully, and use technology to promote vaccination. The next slide offers recommendations based off specific or common topics. And some of the recommendations include tailoring information to specific audiences being addressed, presenting the vaccination as a default approach, and developing materials using health literacy best practices that focus on messages that's both center the child and the community. And the next slide, please. These message framing techniques can be used to assist with delivery. These are proven methods that include telling stories with the bottom line meetings, and use caution when addressing vaccine misinformation, and use evidence-based messaging. The next slide, please. And this particular slide offers direction by category as parents may express hesitancy about age or gender. And some parents may say, why are boys giving a cervical cancer drug? And so that would just really mean it's up to the provider to offer that correct information that the vaccine prevents more than just cervical cancer. And these suggestions here offer very concise ways to respond if a parent also asks, additional questions, like if a parent relates the vaccine to increased sexual behaviors, a simple response would be this. This really isn't about sex, and the HPV vaccine is about preventing cancer. Next slide, please. And I think this is about it. So I'll probably use this to sort of close it out. But a one size approach does not fit all communities. And begin by listening to the community needs and concerns, and consider that the needs should be tailored to an individual, and to the individual, or targeted, contextualized to the community. No single intervention strategy addresses all instances of vaccine hesitancy. Through collaborations and wonderful seminars like today, we can both effectively make a difference in where somewhere falls along the confidence continuum and help them to fully achieve the end goal of developing and accepting the best approaches and leverages to build confidence in vaccination. The recommendation is that HPV vaccination is the norm. HPV vaccination protects the people who receive it. HPV vaccination is cancer prevention. The vaccine supports family by protecting the ability to have children and helping people stay healthy to see their grandchildren. And so I do want to give just a little bit of time for questions. And so sorry about that rapid presentation. I hope it wasn't too painful, and sorry about all the tech stuff. I swear, the best laid plans.
Yes, I will share the slides, but I will go ahead and head back to the main room in case anyone has any issues in there. But text me if you need me.
We appreciate you,
Thank
Katie.
you.
Bye.
And I'm willing to clarify or offer more information on anything that I sort of rushed past. I wanted to make sure I left time for us to talk and try to get as close to as time as possible. So. Oh, maybe I could have slowed down if there are no questions.
You could also put questions in the chat and I would read them out.
I also want to say that we're really, and you guys, I heard you talk about your local efforts, like Immunize Arkansas. We have an Immunize Tennessee that's more centrally located in Nashville, and not necessarily in Memphis. And so part of what we're doing is coordinating local efforts to sort of galvanize community partners to begin our own local roundtable. And so if there are individuals on here who'd like to sort of support us or even jump in and be a part of our planning, we are open to having you join us, and we'll try to drop that link or information in the chat as well, just so that you can register or join us at any time. And I see where my colleague Julia has put our um, web address here, as well as our our email address, web address and email address. Well, I'll take it as clear as maybe muddy water. um, and maybe there are no questions at all.
Okay, so I'm gonna stop the recording.